can be slowed down. But post 60, what is the rate of deterioration of muscles? Which people don't recognize these particular facts. Around 3%, 2 to 3% of deterioration of muscles is happening on an everyday basis, every year basis. Okay, every year basis this deterioration happening. An Indian woman, post-menopausal, staying inside house and doing kitchen work, having a shoulder like this. Okay, this is a very typical case where you can see a sarcopenia coming up at around 20, and that is for 50 years, and this has to be. So, I work with Dr. Sanjay Pai. He sent all these 90% of them today to me only. So now that's how these shoulder surgeries come in knee replacement cases, maximum. 2 or 3 years post the replacement, you have shoulder patient. Approximately 30% of these total knee replacement cases have shoulder problem because years and years they have done this together. Okay, so it impinges shoulder in front and it comes. Many people accept the surgery, many do not accept the surgery. So I get to see both the groups. Today pseudo paralytic, a year later lifting that. You understood? So basically, it is not that a pseudo paralysis today which has happened. After a year also now they are pseudo paralytic. But if you tell 100 people, see, as doctors we are very powerful. You can understand a lot of people by seeing into their eyes itself, I suppose. As soon as you grow up, fear can be manipulated. Okay? And you tell them something which is very truthful into your eyes, in looking into their eyes and perfectly truthfully. Many of them will accept and come for the procedure. So in the COVID time, I had a guy who had got an injury, pseudo paralytic. Surgery could not be done. 6 months later, he came with his hand, then the other hand is not lifting. Now this time he needs conservative care. So that's what the situation are. So based on these, I'm just trying to look at, so the first principle should be that you create no more harm to anybody. Okay. And this should be a part of our life itself. And natural history of rotator cuff disease primarily is sarcopenia, lifestyle issues. So anyone who comes with a shoulder problem, I would say, if I do 100 shoulders in a year, when we send for cardiac evaluation 50-year-old persons, every single year, 5 of them or 6 of them are unfit because they're having coronaries. So I find a very strong relationship to heart issues on people coming with, not just with left shoulder, also on the right shoulder, sarcopenia coming off them, metabolism, tendinosis, partial tear, full tear. So it's a spectrum. Okay, where does frozen shoulder come up in this spectrum is when there is a partial tear coming up. Those partial tears which are having a better tendency to healing go in towards a frozen shoulder kind of picture where they do not really progress to a complete tear rapidly, whereas another group of people just go from tendinosis to a tear rapidly. With diabetes and thyroid may play some role in some tendinosis which goes for a frozen shoulder. But the spectrum involves that frozen shoulder also. So when cases of frozen shoulder come, so how do you diagnose a frozen shoulder? What do you think? The frozen shoulder by definition is like this. All movements are restricted, but rotations are primarily more restricted than the other movements. Okay. Now in frozen shoulder, there are 2 types, primary and secondary. And the secondary is quite common. That is because of a partial cuff tear. Okay, you may have an interstitial tear, you may have a bursal tear, or you may have a past third kind of tear, and the patient may be, and the MRI with the present classifications like Elman classification and all, it is up to the person who writes that. You understood? So every single partial or anything can always be put on this side or this side. It depends on you. Now, which one would you choose in your life for that particular patient? So how powerful doctors are, isn't it? So consider this. So this guy, Ben Kibler, you would have heard about him. Ben Kibler's work is very, very cardinal in understanding of scapula. So who was a guy who brought in the scapula and the scapular function in all these things. So his study is like the most important studies. So he told Rotator cuff you should not repair if a person can't get up from a chair without holding it. Because the first thing you should do is get his other areas work. Okay? So a person who is held by parents and mama is standing walking like that is not a person to be taken up for a cuff tear if there is a cuff tear there. The muscles to be needed to be worked on. Okay, the partial cuff thickness. So these throwers. Yesterday, I'm Doctor for Sports Authority of India and Hockey India for the last 13 years, and I treat almost every single man, woman, junior, senior who gets an orthopedic issue. Now, yesterday I went gone for my clinic there. I saw a 22-year-old volleyballer. Okay, he's having shoulder pain, and 1 year pain. 3-4 months they did rehab, didn't find anything. MRI didn't find anything, so somebody suggested I'll do a subacromial decompression, and subacromial decompression is done. Today is 1 year from that subacromial decompression. He has gone back to play, and as soon as he went back to play seriously, 3 months, his same pain has recurred. Okay, so the surgeon who has done, as probably will never see that guy again. What he thinks his surgery is successful because first 6 months he didn't say anything. But when he went back, it's causing the same very problem. So understanding that every pain which is not subsiding by the rehab that you are giving does not mean that the patient has to be taken up for a surgical procedure. So the partial thickness rotator cuff tears, the questions we need to answer is, what is the natural history? Will every case go for a tear? You should recognize that it is not at all the truth. And when should I repair a partial tear? And what technique of repair should I use? All these are the present, if you go for any conferences, these are the things. Okay, so this group, I think, is well there in the internet. Each one of you should read about it. The Moon Group in 2024, as late as that, received the prestigious award for determining effectiveness of physiotherapy for atraumatic, not asymptomatic, atraumatic symptomatic cuff tears. Conservative care, nothing happens. Okay, and the ARC trial is again, it is 10 years prospective, so it's not yet completed. It is going on, and comparing operative to non-operative treatment of cuff tear, which is atraumatic. That you group one person you take for surgery, other for non-surgery, and see whether the progression is happening on the non-tear group or the repair group. Everyone is healing or not. Okay, so science is not completed itself. It's in a course. We are learning. Now, pain does not correlate with cuff tear severity because I have seen a lot of cuff tear arthropathies coming without much trouble. A lot of patients come. I'm talking about my knee replacement cases coming from for shoulder pain to me. In the end stage cases, they come. They're not having much symptoms. They are ready to live with it. Whereas some do not. So recognize this. Everything is not painful. Activity level does not correlate with cuff tear severity. Okay, so if cuff tear looks bad, doesn't mean that the person. So I have now in Apollo 4 major surgeons, physicians with bilateral severe cuff tears last 3 years treated very much conservative because they just don't have time to come for surgery also. That's all. And they are big people. It's not small people. They are 25, 30 lakhs plus monthly people. Means they really are big people. They just don't have time. When they're doing well, bilateral. Okay, so they do well. It is not some key conservative care can't be given.
If they don't come, how will you become 25 plus? No, he is also 25. No, when you said big people, I thought they were big people. Yeah. No, I was not able to judge what basis you are calling them big people. Suddenly, when you said 25, okay. We still a long way to go.
So now this again, does failed cuff repair hurt? What do you think about it? It's a very common thing, unless you read literature, you will never understand this thing. Failed cuff tears should hurt. The answer is failed cuff repairs have same passive range of movement, pain level, and function as those that heal. You will have a lot unless and until you sit down and study these people. The only difference that will come is the strength is better in the repair healed people. Okay, may not even show proximal migration. So this is a loophole. All surgeons can operate everything and never take the MRI, never study it. I've done this, I've done that. I repaired using Mason Allen, Squai, and thinking that this is healed. No, it doesn't. So basically, Dr. Maheshwari, Delhi, all of us have read his book also. Recently, he made a comment in one of the group telling about this particular thing. What he told, that I stopped repairing cuff tears because I don't think aging can be reversed. And because he feels that it doesn't heal only, but that is going to the other extreme of the story. And then there's another extreme that every cup tear needs to be, whether it's partial, quarter, or pasta or interstitial, needs to be treated. So where is the balance? Each one of us has to individually decide where we will go. And what about progression? Partial cuff tears. What is happening to a little minor cuff tear which is there? Only 48% cuff tears progress. It's not even 50% told. Okay. And progression is associated with pain. Yes. When it progresses, pain increases. So patient who is put on partial cuff tear and you start treating them and the pain goes away. And then after 3 years they come, when they stop doing those exercises, that's what happens especially. Sarcopenia progression, the pain can, and some tears can become irreparable. So when fixing cuffs can prevent this issue and all these things, that's just you talking to your patients and keeping them in your loop and offering a proper advantage. Now, surgery may or may not change the natural history. It's very important to know this particular surgery may not change the present thought processes. So this is the thought process only, though it's not. It may change is what we want. And it should not progress to arthropathy. So understand this particular thing. The likelihood of a recurrent defect. That means when you operate someone and you repair them, the tear recurs or the extension of the tear, that is when in non-repaired, was not different between the groups. This is the ARC study findings coming up, but it's not completed yet. So 10 years is what they're looking at, and then 15 years. It's a long time. So surgical repair may not alter the natural history. What is the early cues coming up? So you may have some people who are getting for healing, but in those group, everyone doesn't heal. And all the cases which are not treated don't go for progression. That is the meaning of that. So massive cuff tears comprise 40% of all randomized controlled trial. Patient with massive cuff tear can respond favorably to non-surgical treatment, and non-surgical treatment should be attempted for 6 months prior to surgery. So all general recommendation, and non-surgical treatment should be considered for patients with medical history, means uncontrolled diabetes, thyroid. All such people needs to look at this. So, and this is the first part of it. The second part is ANLO studies. I'm talking about Canadian system, where they try to look at between 2004 to 2006 in a tertiary reference center, what is the thing. So they excluded based on these points, and they put in these number of patients, 76 patients, all 52 plus minus, and group 37 non-operative and 39 operative, and they followed them up. So the progression, dominant arm, trauma history, and tear extent, was the indicator that it will progress. The follow-up of the non-operative, quite interesting to see if they fail for the next 48 months. They found that only three had ongoing symptoms. They were put on proper physiotherapy. All others settled down at 2 years. Only three had ongoing symptoms, and that was the finding of that. And mean 53 months, and two different muscles followed them. 9 patients, only 24% of the total non-operative group progressed, and 24 patients had no changes coming up in the cuff tear. It remains the same. And in fact, what is commonly told, nobody heals, 11% improved. On radiology, I'm talking about. So MRI, the partial tear, which is more than 50% likely to progress, does not mean will progress. But how we speak, likely it will progress. It will not progress. It depends on you, how you will say it. And less than 50% the tear, 14% progress, and greater than 50% tear, around 55% progress. So partial tears, what are they? These are the three types. Okay. Now, on the capsular side, that is the pasta side, it's not really a muscle tear. It could be a more capsular tear with less of that supraspinatus tear. And then the bursal side will be more tendon compared to the capsule. So this volleyball guy and all subacromial decompression, exactly at 1 year, the guy is again at the same. When he going to hit, so what would be the change for him? Now he had pain before he went, did physio, did not get relief. Now somebody did arthroscopy, found nothing. Did a good subacromial decompression, standardly. 6 months, no problem. And he went back to game within 3 months, same pain comes. What will you do now? How will you manage? So there's where your kinetic chain, isokinetic analysis, and where exactly is his. And so I was just seeing him. I observed him for 20 minutes. We were having studies of how his body is moving and all this. We found that this guy, this deltoid is hyperdominant. You understood? And many of his glutes and all quite weak. So what he does is he uses all force down there and trying to. So if you have 100 muscles, use them. If you are in a sports guy, you just cannot be hyper-dominant on one. And never uses his left for the shots. My father was a national volleyball coach. So he used to often say, in your practice session at least, if you are hitting 70% of the time with your dominant hand, your other hand also should be used at 30% so that the other opponent cannot predict you. Understood. So that becomes a big important thing about. And this full pseudo paralysis guy is coming COVID and then regaining full movement post traumatic also. There are things when you see these people you get. And there's a guy called Joy Arun Kumar, one of the patients whom I operated. So it was operated by one of our esteemed members, base rotator cuff. Within 15 days, he felt that whatever has been repaired, ruptured. He came to me and I saw him. I told that, I'll be repairing it again. And I went in and I repaired. I immobilized him properly done. First surgery is also properly done. Second time also we properly did. We um, augmented him also. Within 6 months, that is third month, we executed an MRI. Good and nice. 6 month MRI, dicey. By 1 year, cuff is back in its original place, far away from where it should insert. Okay, so these things miserably fail, and some really become. All of us have done trauma. How many times have you used biceps as the lighthouse to find out which piece is which one? And how many times have you found that the biceps is not there? Biceps is a very, very, very important thing. You understood? It's not something to be cut off and put somewhere and all those. It needs to be something which has to be. We don't know exactly its function. It's not yet known. But impunity with which it is being cut, you have to be careful because we don't know whether it is one of the factors in proprioceptive level to prevent the proximal migration. You understood? We don't know what is it. But then burst of patients, recently I had a trauma case where there is no bone only, but then the bicep tendon is able to handle that whole thing and keep it there. Okay, so what's the message I want to is think before taking irreversible steps on others' body. That's all is the information I want. You have to understand how powerful you are. When you are taking a decision on other people's body, think before doing it. Thank you.
You have another talk? I was under the impression that if you're talking on MRI lesions.
Yeah, I got MRI, but then I got those things.
Because that is another important aspect.
Very, very. And I got 4 or 5 of, but then it takes, it's not cannot be 10, 20 minutes. Because the MRI today also, I was just.
I show one MRI.
Yeah, I'll just show you today. So I'll show you today.
One pertinent problem what we face. Because we often read the MRI report given by the radiologist.
Now today morning, so
we have to learn to see the MRI films.
See the most common thing now, all the shoulder problem patients go to cardiologists, go to neurologists, neurosurgeons, the spine surgeons, then or the physiotherapy, and then they have come. And they have already made their diagnosis and they have got MRI. First thing they say is that they take out the MRI and they have done 2-3 MRIs. And that's what most of the people get confused and they just look at the MRI and then they forget the patient. Whenever I have seen these shoulders, I was more confused. I'm even more confused after coming from. I got up no man, this guy
I
is
think
come
you
with
should
this kind of
give a list
thing.
of
But
patients
looking at him, I don't think he needs a surgery. What do we do? There's a 44-year-old guy. He's a stunt master. He does it.
Either patient profile
Very
or